today I'm going to talk a little bit about the study that we're doing at Vanderbilt University, funded by the National Institutes of Mental Health. And as you can see on the slide, I have a range of partners, state partners. So our State Department of Education, Department of Health, TenCare, and our Mental Health and Substance Abuse Agency are all fabulous partners. I have to give a special shout out to Assistant Commissioner Lori Paisley, who's been amazing in supporting the work we're doing. And I also have a couple of my collaborators in the audience today. If you feel like outing yourself, you can raise your hand. I am going to just jump right into why did we propose to do this study. And one of the reasons is that we don't have a lot of knowledge and research-based evidence on what is working effectively for our youth today. As we've been talking, circumstances are dynamic, right? And the pandemic changed a lot of things. And so our research is trying to fill some important gaps in literature. First of all, you'll see, of course, as things, mental health conditions among children have been trending, it's important to understand what's happening over time. The landscape of how we serve them has been very dynamic, and so we are actually using data, which I'll describe in a minute, that allows us to follow individual students over time and schools and what they're doing to understand how we're serving them and what the outcomes are. Commissioner Marie Williams mentioned earlier, we need to know what works, and that's part of what this study is about. But we also understand that we can't just do this with data that we're fortunate to have gotten from our agencies. We also need to do this by talking to the people in the school districts. So we are also, and this is where Assistant Commissioner Lori Paisley's help has been so important, reaching out to our school districts to learn more about exactly what they're doing. Just a brief slide to illustrate what we've done in terms of actually combining administrative data. The information we present today is just based on the data we've linked from 2006 to 2019. We're currently linking through 2023, which will take us through the pandemic. But you can see we're linking children's health and education data, as well as information from TenCare, important information about their health and their educational outcomes over time, so that we can follow students in their progression, their health and their educational success. One of the things you'll notice in the corners, we have a very large sample, right, of observations over time, over 14 million observations of children, and we cover almost 70% of all kids in Tennessee at some point in the trajectory they've had a Medicaid record, which says a lot as well about our population. This is an example of just some descriptive information we get from looking at these data, where we're looking at the rates of mental health conditions of Tennessee children over time. And you'll see that before the pandemic, those rates or prevalence of mental health conditions nearly doubled, okay? And so, there's just the plot of all the school districts on the one side, the kind of messy looking plot, and then you can see the trends by whether they had any kind of school-based health center, school-linked center, mobile health, telehealth, or an AWARE grant, which I'll talk about has been very important. The Project AWARE grant was mentioned. We've actually been fortunate in Tennessee to have 10 AWARE grants over 3 rounds come to Tennessee. These are very important grants that help build the mental health services infrastructure we have in schools. So as we've talked about today, schools are oftentimes the first-hand observers of when kids are starting to encounter mental health challenges, and it puts us in a position to help serve their needs. So my map is a little more complicated than the one you saw from the Sigmar Institute, and one of the things we realized was there was no one source of information that was really adequately capturing what we have in our school districts. And part of that is because it's dynamic. We see a lot of changes over time. For example, if you look at the notes there, 21 of our school-based or school-linked health centers, telehealth, mobile health, started in 2020 or later, and some have started and stopped at different times. Part of this is just some of the challenges we have with sustaining capacity for a variety of reasons. From the interviews we've been doing with school districts, many of them, these are coordinated school health directors who really do fill this key role of coordinating resources and personnel in the school districts. We've heard from them how they really draw on a wide range of grant resources. We've heard today from the Commissioner of Mental Health and Substance Use about those mental health liaisons, such an important particular resource, but not all districts have them yet. And so a lot of school districts are building partners using other grants like the Resilient School Communities grants to try to bring staffing into their school districts. But we have to recognize, we heard from the last panel, that funding is critical. And so some of these grants are time limited, narrow in scope or focus. And so sometimes school districts have to start and stop and restart again. And these partnerships that they have also depend on those provider partners, your federally qualified health centers, having the staffing capacity. So some school districts have developed MOUs, but then it's difficult for those providers for various reasons to always be able to fully staff as contracted. So we've just been amazed at how innovative and hardworking people in school districts have been. Now, what we're trying to do over time is measure empirically, what happens when we begin to introduce these resources into school districts? How does it affect our diagnosis and service to students with mental health conditions? And so I'm just presenting some just really basic overview for you of the findings to date. So, for example, we are looking over time as school-based, school-linked, mobile health telehealth centers are introduced, and then looking to see what happens, for example, with diagnoses of conditions. So you might expect, we've heard from AWARE grant directors, that when you first get these resources, that's sometimes your first opportunity to identify students with these needs. So we might actually expect seeing increases, right, in identifying students with these needs. But we do, in fact, see that when those resources come in and they are utilized, that we do see improvements and reductions of prevalence of students' mental health needs. So on average, so far, we're seeing about a 6% reduction from baseline in students with mental health conditions when these resources are put in place. But if you look, for example, at Shelby County, we can also look by district. They've realized a 20% decrease in diagnosed conditions from their baseline rate. And then Hamilton County, which someone mentioned Chattanooga, has a range of amazing partners. They're also bringing resources to begin school-based health centers more recently. But that we've seen has led to a reduction in diagnosed behavioral health conditions by about 21%. The other thing we're doing, I'm trying to be quick here, I know we have limited time, is we are creating these kind of case profiles. And this has been, the district, we can't do this without the cooperation and collaboration of people in the school districts. We're documenting what are the innovative things that they're doing, what are the challenges they're facing, how are they staffing their school districts, and trying to highlight. So our goal as we do this for all the districts that we're interviewing is to put together a searchable book that people can use to look at, here's a school district of my size with this many schools and staffing, what are they doing that we could maybe adapt? I just want to quickly highlight, this is another school district, this is Unicoi. Someone mentioned earlier today the fact that our state senator did that the students wanted a mental health day and they didn't get that in legislation, but here's an example of Unicoi County School District partnering with ETSU, East Tennessee State University, to create a reset room where the kids can go kind of, reset, get some peace and quiet, come back in, and rather than leaving school, if they're facing kind of some mental health challenges, go to that room, counselors track students' use of it, that helps them to identify kids who are needing that space more often, and then help maybe connect them with additional resources. They've got a place the students can link for telehealth supports in that room, exercise equipment, all kinds of things. This is one example of many innovative things we've seen across the district. We're in just the start of the second year of a 4-year study, so we expect a lot more results to come out. There's a lot of work in progress, and we are very excited to share these out with you over time, but also to be of service to you. So please reach out to me if we can help you in your work.
I am so grateful for having the opportunity to be here today and learn from so many of you. I typically do work and talk with folks in a really different circle, so it's been really refreshing to hear about the youth mental health crisis from really different important lenses today. So my charge is to bring tech and social media into today's conversation. And I'll kick off by acknowledging that whenever I tell someone that my job is to study teens and social media, the majority of time the response is, OMG, it's so bad, right? This knee-jerk reaction is probably not surprising, especially when we're swimming in headlines that look a lot like this. Social media is taking a dangerous toll on teenage girls. Screens are poisoning kids' minds. Headlines like these make it seem like every teen is having the same terrible experience of social media. And they appear to deliver a verdict that social media is driving the adolescent mental health crisis. And that's why it's been refreshing to be here today, where tech has not been mentioned once. Naturally, the other headlines show schools are trying to find ways to help, including via phone bans or even legislating tech companies or litigating tech companies. But I and other researchers in this space know that the relationship between tech and youth mental health is not so clear-cut. And consequently, the struggles that teens are having are not readily resolved by simply reducing screen time or pulling the device. So how did I come to this stance? For over a decade, I've been working with a developmental psychologist named Emily Weinstein, and she and I have been carrying out extensive research on this topic. And a key feature of our work has been adopting a pedagogy of listening to teens, really partnering with teens from different backgrounds and identities, and in nearly everything that we do. And that partnership has been absolutely transformative. Our assumptions have been checked and challenged left and right, and I super appreciate the last panel really emphasizing youth voice. Couldn't agree more. The kinds of questions we've been asking young people are a really important part of this. So repeatedly, we ask teens, what are adults missing that you most need us to understand? And this is such a generative question. I highly recommend that you ask it of any teen in your life about any topic, but especially tech, because there is so much that adults are missing. Our book, Behind Their Screens, is filled with a variety of insights, but I'm just going to highlight a couple in my short time. When we listen to teens talk about tech, we hear the story that tech is really both and. Teens tell us about so many positives for their learning, for geeking out on interests, for civic development, for connecting with people around the world. But the good stuff nearly always coexists with challenges, and challenges that are often misunderstood by adults or missed entirely. Like, let me go back one. Like the pull of the screen. Adults often assume that teens want 24/7 access to their devices, but many teens tell us that they really struggle with the feeling of being sucked in, and they don't like feeling dysregulated. When it comes to friendship, tech can also be both a burden and a boon. On the positive side, teens' text messages and group chats are crucial spaces for connection and mutual support. Yet the fact that technically a teen can be available 24/7 can be really stressful. When a friend reaches out for support late at night, a teen can feel like disconnecting for sleep or self-care is coming directly at odds with their sense of empathy, their desire to be a good friend. And for the teen reaching out and waiting for a response, specific tech features can amplify concerns they have about friendship status. So a signature example of a tech feature is read receipts, which can create the experience of being left on read. When you've sent a message, and you know the person has seen it, but they haven't responded. So especially for adolescents, this can trigger feelings of vulnerability. I know they read my message, they left me on read. They must be mad at me. We're not friends anymore. So that's how the thinking goes, often into an automatic negative spiral. This is a classic thinking trap called mind reading, or a cognitive distortion as described in cognitive behavioral therapy. It's when you assume that you know what someone else is thinking or feeling. Another thinking trap that is fueled by technology is all or nothing thinking. So social media highlight reels can fuel the thought, especially for adolescents, that all of my friends have better lives than me. So we are all vulnerable to these kinds of thinking traps. You may be relating to some of them as you sit there and listen to this and think about being left on red. But adolescents especially are developmentally inclined to engage in natural second guessing, really caring what their friends think, how their friends are feeling, really feeling the need to be connected and validated and affirmed. Now, to be crystal clear, tech features don't cause thinking traps, but they can grease the wheels of these lines of thinking. As we've listened to young people's experiences, we've thought a lot about how we can support them around things like that, things like this that are really hard. So in the case of thinking traps, we've worked with an interdisciplinary team of educators, clinical psychologists, and teens, importantly, to create resources that help teens recognize thinking traps when they come up in their own thinking when they're using tech, and importantly, develop strategies to counter negative automatic thoughts. So these are some examples of resources. If you follow that QR code, we've created a really compelling video in collaboration with KQAD, as well as a glossary of thinking traps that helps to identify and label these kinds of cognitive distortions. More broadly, in the work that we've been doing at the Center for Digital Thriving, we think a lot about what it takes to thrive in a world with a lot of technology in it. And we believe that the key is in supporting teens' very sense of agency. Now, psychologists have long recognized that well-being is associated with feelings of agency. We define digital agency as having meaningful choice, intentionality, and control over the way technology fits into our lives. And this is for all of us, but adolescents especially. That's our focus. So what might digital agency look like? These are some emerging indicators that are really guiding our resource design process. So teens cultivate mindful tech habits. So they have strategies to counter those feelings of dysregulation that I mentioned that many teens tell us they struggle with. They have strategies to avoid design tricks and thinking traps. And teens know their values and can align their tech use with them. So the resources displayed here on the screen are things that we've designed through that process I've mentioned of working with clinical psychologists, educators, and teens that really support these elements of digital agency. Now, I want to be crystal clear. Empowering teens with better skills and strategies is not the only thing we should be doing collectively. We absolutely need policy changes. We absolutely need tech companies to prioritize well-being over profit. But we also know that teens need support and strategies now. So I want to end this talk with the idea of agency and an invitation to consider how all of us, whether we're an educator, a researcher, a policymaker, can help support young people with a sense of agency around growing up in a tech-filled world. Because ultimately, we want a world where youth can thrive however technology fits into their lives. Thank you.
Saw the title of the conference being Connecting the Dots. Some years back, I was working on a deal to get AT&T to invest in our communities and schools movement. And they said, why should we do that? I said, we're in the same business. And they said, what do you mean we're in the same business? I said, we're about connecting the disconnected. And we're trying to get disconnected youth connected to the resources they need to not only survive, but to thrive. Communities and schools came out of my own experience of being kicked out of school and in trouble, and I was part of a group that was hurting other people, and a friend of mine that got helped at the same time was putting a needle in his arm. And I didn't know that we were going to symbolize the power of hope, because both our lives were turned around by somebody coming to the streets and loving us into change. One of us was hurting people, the other was hurting themselves. And that's why I was so glad to hear the word hope here, because hope is the deciding factor. Because when you know somebody believes in you and trusts you and is willing to be with you, you get hope for your future. You believe that maybe you weren't so bad as people said you were. So I got to spend the decade of the 60s working on the streets in New York. And I'm a slow learner. I have graduate degrees in ADD, ADHD, and PTSD. And I have 3 freshman years of college, which totally qualifies me to be up here. But I learned a whole lot on the streets about what makes the difference in a kid that makes it and a kid that doesn't. I had, for 5 years, I had over 30 kids from the streets living with me. I saw which ones died and which ones didn't die. I saw the differences in it. So at the end of the 60s, I got into education, not because I knew anything about education, but so many of these kids would get on the straight and narrow. They were so far behind in school, the only alternative was to sell drugs. So I wasn't allowed in the schools back then. I wasn't as nice as I am now. And we had these storefront schools, and we learned a whole lot about them, of kids from the streets. We could give GEDs back then. But because of that history, in the early 70s, they had these commissions studying the riots. And people said, why'd you get invited? I said they were looking for a white guy with long hair who had been in a riot. And it was then I was to see CIS take birth, because they asked me what I thought was going to be the next big issue in America. I said, the next big issue in America is that we're going to win or lose the future of America at the schoolhouse door, and you're going to think it's an education issue. I say it's a breakdown, a community issue. And I said that we've lost the safety net for children. We've lost the village. And what we were witnessing in the 60s, that the kids living with me weren't dropping out of school because of education. It's because nobody knew their name. Nobody gave a damn they were on the streets. They had no future. They had no place to live. They didn't have food in their stomach. They didn't have academic problems. And then I started getting sympathetic toward the schools, because I saw teachers more and more being asked to be mother, father, sister, brother, social worker, hall guard. And I said, if we don't turn off the faucet of the schools, we're going to continually bail out the basement of the community. And I said, we're losing 1 million kids out of the schools every year. We got to go in and free the teachers up to be teachers, and the principal be the principal, so that we can bring the resources to where the kids are. I said, kids need a PhD in systems to get help. The health workers are over here, the police are over here, the faith people over here. So I said, why don't we bring them to the schools? Surround the teachers, free the teachers up to be teachers, and the principal to be the principal. So this isn't a program. We said we have to change the whole delivery system. So we came up with an idea. We put a person inside the school to integrate all these services to surround the schools. I guess you call them wraparounds now. But whatever you call it, it's creating a community that deals not only with the individual mental health of the kid, but creates a healthy environment. So you see these 5 basics up there. I had to have something to organize them around. The number 1 is the key. Programs don't change people, it's the relationships. I'm alive not because of Facebook, it's because somebody came in my face and believed in me and believed I had something to give, or I wouldn't be here today. We wouldn't be in 3,300 schools. So anyhow, what we do is organize around those schools by putting, maybe the best way to do this, I was cutting a deal in the early 90s because I was told I had to have cumulative knowledge to have a longitudinal study so that we could affect policy. I said, those are 2 big words, so I know they cost a hell of a lot of money. So somebody told me the place I should go is Cisco Systems. So I spent a year going out there, and I finally got to meet with the guy that invented it and the head of it. And they said, why should we invest in you? And I said, because you aren't going to have a workforce if we don't keep these kids in school. Then he said, well, what makes you different? I said, our router. Now remember, this is 1991. I knew this much about a router, but I said it anyhow. I said, you have a router that organizes and figures out how to disseminate, gather, and distribute information. It's going to transform how we connect with each other. We put a relational router inside that school train, just like a nurse in triage that's there at the door and knows which kids need a hug, which needs food, clothing, shelter, and which kids are gangbanging or using drugs or shooting people. So you're there as the street, and you're building the trust, and trust is key to hope, and hope is key to change. So what we've done is, so far, in 3,300 schools this year, we'll have over 1 million kids in the program, all Title I, and we've been able to keep 98% in school this past year. It's a movement that you got to create a delivery system so that you can integrate all these resources. We need to move from partnerships, which are unnatural acts between non-consenting adults, to collaboration, which is a huge improvement. But we are in the age where we need to integrate our services so that we have an orchestra of change. I'll end with this. I get a lot of help from the music industry because of my great voice. I was meeting with Quincy Jones to help open LA years ago. And I said, these people in Washington don't seem to understand me. And he said, I understand. He said, you're telling me the piccolos are playing over here, the violins are over here, the trombones are over here, and you don't even have a conductor. They're all in their own little world. So we need to create an orchestra of resources to deal with Tier 1 mental health, as those kids know, and somebody gives a damn they exist. And believe in them, hear them. Love is the only transformational thing we have. And then you have to have a way to refer and partner with all of you that have all the expertise on getting the right resources to them in the right way. Anyhow, that's what we do.
Good afternoon. Wow, what a privilege to be able to join you and to share this stage with such an amazing speakers. Thank you so much. I'm originally from Brazil, and I want to tell you a story about change. I came to the U.S. in 2000, and I arrived in Lubbock, Texas. I come from a city full of mountains, and I went to the place that has the flattest environment I have ever seen. But when I arrived there, I learned something that was very unique. I discovered that in the United States, people don't call American football American football. They only called it football. Now, if you understand, I'm from Brazil, and I know what football is, and it was a big conflict. I did not understand why they called it football, because I got to go. And I had a roommate that felt it was a project of his, that I needed to know everything about the rules of the game of football. I was in Texas, and he took me to one of the most amazing things I experienced, and that was Friday night football. I did not know it was possible to have stadiums that big for a high school game. But I got to love the sport. I got to learn the rules. But I have to confess that even though I kind of accepted the differences, I had to resent American football a little bit, because most of the game was not played with the feet. And they were telling me that the sport that I loved was called soccer. And I had to change, because folks did not want to start calling American football American football. They were pretty settled in Texas. We have all known and have inevitably been shaped by this idea of having to change. I want to say that I'm not necessarily against it. There is a reality that we, as human beings, appreciate stability. We appreciate predictability. So much so that we are surrounded by systems that exist in order to perpetuate the status quo. Yet we have seen, and the conversations today point to that, is that those systems over time, they tend to be unsustainable. Often we realize that they are not really applicable to every setting. They often tend to not account for everyone in the community, yet we don't know how to change them. What I'm wanting to do today is to maybe produce or present a rethinking, a reimagining of one particular system that I'm really involved with, and that is the healthcare system. I would like to introduce to you something that I've been involved with and have really dedicated a lot of time to trying to implement here in Middle Tennessee, and that is the idea of integrated healthcare. Now, before I go any further, I want to say that I'm coming at this conversation as a mental health provider that had to learn to change my perception about my own discipline and what a counselor or a psychologist looked like. Now, I think it was 2017, I watched this talk by Tom Sebastian, and he introduced me to the story of Emma, and I want to read this to you. Emma is a 4th grader. Her teacher expresses concerns that she is often absent-minded in the classroom. At times, she is falling asleep. She's making frequent visits to the school nurse with a variety of complaints, aches and pains. Emma's mom, after struggling to secure a day off from work, takes her to the doctor. Her doctor, really busy that day, is likely to have just a brief visit with her and give her a diagnosis and a treatment and sends her home. Unfortunately, without maybe having had the time to assess all of her needs and presentation. So how does that play out for Emma? Now she has been to the doctor. She's continued to having difficulties in the classroom. Maybe now she's not only getting in trouble at school or having difficulties at school, but also at home. And she's having to navigate with all these stressors on her own. Now, I remember hearing this story, and the hard news is that I've probably could tell you of dozens, if not hundreds, of stories similar to Emma. As a nation, we have an abundance of healthcare facilities. We have cutting-edge technologies. We have state-of-the-art pharmacotherapeutics. We're really the envy of the world, but we are also a nation that, for a myriad of reasons, are not able to provide those services to all of us. We are observing a significant gap in access to and quality of mental health and physical health in the populations that we serve, especially those that are minoritized in our society. To add to this issue, data shows that when individuals are able to access or afford health care, the vast majority of them will not accept a referral to see a mental health care provider. So they are able to see a primary care doctor, but for some reason there is a loss between that relationship and the mental health needs that they have. These are conservative statistics. About 60% of patients with behavioral health conditions receive no treatment. 50% of the treatment for behavioral health conditions happens in primary care. About 33% of primary care providers only 33% are able to access outpatient health services for their patients. So there are some significant gaps here of how we are able to address the need. Since 2017, we have been privileged to develop a program we call the Lipscomb Initiative for Behavioral Health Integration. Our goal is to facilitate the integration of mental health into primary care settings in Middle Tennessee. And I want to highlight something. One of our greatest partners, Dr. Cynthia Jackson, is here. I wanted her to stand. We've been partnering for many years in training our students and providing services to those individuals that we care so much about. So, how does this look like? How does integrated care look like? So let me go back to the story that Tom was talking about and talk about Emma. So, in this reimagining of healthcare, Emma's mom takes her to the doctor, and the doctor realizes that there's more going on here than just physical illness. Rather than being given a list of mental health providers to reach out to, Emma and her mom are able to connect with a mental health provider in the examining room, meeting a provider that specializes in working with kids. The doctor introduces them to the member of the team, so that trust between the doctor and the family is passed on. We call it a warm handoff. And that person, that provider, continues the assessment of the needs that Emma might have. Now, the mental health provider, the doctor, Emma, and her mom are able to work together to create a care plan that addresses all of those needs. And imagine the day, maybe we can connect this dot here, in which the school system has access to that information. Just imagine that dot being connected. Well, we believe that this approach can be transformational. We've seen this have significant impacts in our community, and there's data to show that nationwide, here are some of the things that are showing up as significant changes. Patients tend to be more satisfied with care when they are able to access services like this. Better health outcomes, lower healthcare costs, increased provider well-being and reduced burnout, and improvements towards health equity. We are changing the way we care about how people's mental health and emotional health is treated. Not as this specialty thing that happens out there, but part of health in primary care, where most folks receive their care. This is what we are working on. And I'll finish with this. I do believe that change is possible. Because often when I tell folks that to this day I play soccer every Sunday, folks will correct me. They'll say, "Do you mean football?" Thank you.